So let me kind of start. I'll have to periodically go back to my notes and pollinate, but I want to start with the myths and the gap that's current in medical care. And I'll show you this book. It's Being Mortal by Atul Gawande, who is a physician and New Yorker staff writer. And on page 1, just to kind of set the stage for where are we with care towards the end of life. Page 1, first sentence, I learned a lot of things in medical school, but mortality wasn't one of them. Our textbooks had almost nothing on aging, fragility, or dying, how the process unfolds, how people experience the end of their lives, and how it affects those around them seemed beside the point. Now, there's a story here and about Gawande. He is a Harvard-trained physician. His father was from the generation of South Asians that came to the United States to go to rural and underserved areas. I worked in a town like that called Chester, South Carolina for 9 years. And we had an Indian surgeon and an Indian OBGYN. And his dad was a urologist in Appalachian, Ohio. And he was the second generation. And he went to Harvard. He is a New Yorker staff writer. He's a surgeon. I mean, when I read his resume, I just want to go home and shoot myself. But his dad, ironically, being a urologist, got prostate cancer and slowly weakened, and then eventually they called and they said, we're putting Dad in hospice. And he said, well, kind of essentially, you know, gee, here I am, a Harvard doctor in Boston. I need to go back to Ohio and show these hicks how to practice medicine. And he got there and talked to the hospice nurse, and it took him very few minutes to realize he had no idea what end-of-life care was about, what hospice was about. And this opened up a whole new vista to him in terms of how he looked at this. So he wrote an article for the New Yorker. It was in 2010. It was called Letting Go, What Medicine Should Do When It Can't Save Your Life. And then he expanded that into this book, which is a #1 Times bestseller. You can Google the article if you want it. But it was basically his kind of, oh my gosh, you know, we never really think about this. So the reason that I mention this is Dr. Gawande is a little older than my kids, and the state of education around care towards the end of life, geriatrics, palliative care, and hospice, is such that the University of Tennessee Medical School just started mandating that the medical students get more than the 1-hour Kubler-Ross death and dying talk, not last May like last month, but a year ago last May. So I went back, I've been a number of things, including a family doctor, an occupational medicine doctor, a hospital system medical director, and my mother passed away in hospice. And as my wife says, I have occupational ADD. So I went back to school and did a hospice and palliative care fellowship at the tender age of 55, and then went into this field. And what I learned was that I'd been practicing medicine for years and years and years, had no idea what to do with people towards the end of life. As a family doctor, it was usually, gee, you need to go see a specialist, and I can tell you the specialist's answer is, gee, you need to go back to your family doctor. There is what we say, the ever popular, there's nothing else we can do, and I'm going to talk about that in just a little bit. So medical education is just now tumbling to the fact that we need to think about the fact that there is an end of life. The Hastings Institute for Bioethics. Come on in. The Hastings Institute on Bioethics said that the problem is, as we look on end-of-life care as a failure of healthcare when it should be considered a part of healthcare. So what we need to be looking at is how do we keep people comfortable in those latter parts of their life. Now, Tim said we're going to talk about myths, and the first one, and Gawande addressed it in his article. He said, I didn't know anything about hospice. To me, the picture of hospice was of a morphine drip in the last few days. And so the first myth is, oh, they give you morphine and you die. And that is not correct. Our goal is to celebrate life. Well, we will give you morphine, but our goal is to celebrate life. It is about when time is precious that we want you to have the best quality of life in hospice. I've helped people go to Myrtle Beach, Disney World, cruise the coast of Maine. These were all on their bucket list. I helped one guy get married in the hospital. I'm not sure I did him a favor, but that's what he wanted, so we did it. But we are really and truly about celebrating life. You've heard Tim McGraw's "To Live As If You're Dying" song, which I have multiple copies of. We all ought to be looking at life that way. There's on all of our birth certificates, there is an invisible expiration date. And if you hear me talk with my family, when we get done, including on my way here when I was talking to my wife, we say, "Goodbye, I love you." And this was made particularly poignant because my wife had a heart attack 6 weeks ago and underwent quintuple bypass surgery. So you never know when that invisible expiration date is going to come due. But doctors really don't know a whole lot about palliative care and hospice. Well, let me try to put this in a little bit of context. Hospice has been in the United States since the 1940s. It was started in England in the 1960s. And it was really kind of countercultural, and it was kind of, there's got to be a better way to do this than just being in the ICU connected to 16 machines and your family not there, and off you go. So they started the hospices, and I'm happy to say that Hospice Chattanooga was actually in practice and working before Medicare started paying for hospice benefits, which was in 1983, and we started in 1981. Hospice is intended for people for whom two reasonable physicians would not be surprised if a patient like this passed away in 6 months or less. And the goal is stay home, be comfortable, and celebrate life as best you can. So we are really about quality of life. And then the question came up, what do you got with people who have life-threatening, life-ending illness, but they don't fit in that 6-month, want to stay home, no aggressive care kind of model? And that's where palliative care came along. I was in my fellowship about 8 years ago, and we would send people home. We'd see them in the hospital for the palliative care service, and then we would, trying to move my stuff out of your way, we would send them home. And I remember sending one patient home, and there was no outpatient palliative care at that time. It was such a new concept. So I had a patient who was on a methadone drip, and we had to make stuff up to make this happen because it was so unusual. And we said, well, now you're going home, you'll need to follow up with your family doctor. About a day later, I got a call from the family doctor going, "Are you out of your mind? Who do you mean tell them to come send them to me?" And I said, well, we're only in the hospital. I don't have any place else to send them. So this is still an evolving field. So palliative care is what do you do for people who are outside that 6-month window, or they're still looking for aggressive care, but they still have a life-threatening illness. And I believe Tim passed around some brochures about palliative care as well. So I've differentiated them a little bit. What I tell people, and it's on the cover of my brochure that Tim wrote, is what do we do? And we are the 3 C's. And this literally came about as an elevator talk. You've heard an elevator talk is how do you pitch your thing in the elevator? And while I was in my fellowship, had somebody get on the elevator and read my part of my name tag, and it said palliative care and hospice, but my lapel was over the hospice part. So he got on and he tried to pronounce palliative care, and he said, "So what is that?" And I kind of stumbled around a little bit, and I said, "Well, we help people try to feel better." And he said, "Oh, my dad might really like that." And I said, "Well, there is one small caveat," and I pulled apart the thing that said hospice, and he goes, "Oh, never mind." And I said, "Gee, I got to work on my delivery." So the elevator speech now is we are about the 3 C's when we're talking about palliative care. That's comfort, communication, and coordination. Comfort is symptoms. What does the patient suffer from in the biblical sense? And that is pain, shortness of breath, nausea, fatigue, weakness, constipation, spiritual angst, depression, those things that are what we look on as symptoms that patients need to feel better from. And I think it was Woody Allen one time who said, "I don't so much mind dying, I just don't want to be there when it happens." And it's about the suffering that goes with it. So we are about trying to help with the suffering. Communication. Now, the word doctor comes from the Latin docere, which means to teach. And so the really sad fact is as doctors, we are lousy teachers. More than 50% of patients leave the doctor's office, according to a survey, not knowing what they're supposed to do when they get home. So communication is a significant issue. The Joint Commission, which is the regulatory agency for hospitals, hospices, and whatnot, finds the single biggest factor in most medical errors is lack of communication. There was an article in the New York Times about a year or so ago that said that doctors were terrible about introducing themselves less than a quarter of the time, and that they usually interrupted the patient within 18 seconds of when they asked the patient what they were there for. So communication is not really a strong point with a lot of doctors. A lot of the fellowship that I did was sitting and talking with patients and being able to effectively and emotionally communicate and connect with patients, talk with them about the fact they had a life-threatening or life-ending illness, and be able to get through to what were their wishes and desires. Another thing is about prognosis. Doctors hate to give people prognoses. Part of that is nobody wants to look stupid, and prognosis is an excellent chance to look stupid. You know, I can't tell you many patients. I saw a patient, in fact, last week, and he said, I was diagnosed with this, and they told me I had 3 months. And I said, how long ago is that? And he said, 4 months ago. And I said, yeah, what do we know? But it is important because it not necessarily how many days, how many weeks, but to give you a sense of order of magnitude. So I talk a lot about patients. I always start with, I'm not God, but we talk in hours to days, days to weeks, weeks to months, months to years, just to give people a sense for how long they've got. I had one gentleman when I was in my fellowship, and he said, so doc, nobody will tell me, maybe you will. How long do you think I've got? And I started with my little, I'm not God and whatnot, and I said, I'm thinking probably, a few weeks, plus or minus. And he said, oh, thank God. And I said, I'm sorry, what did you say? And he said, I said, thank God. He said, please explain that a little more. And he said, well, the way you guys have been padding around my room, I figured I had maybe an hour, maybe a couple days at the most. And he said, you just gave me a month, thanks. And I was like, well, I guess it all depends on your perspective. Study of doctors showed that 63% of doctors would not give a patient a prognosis when they had one. So it's reluctance. It's talking about very painful, uncomfortable things. God forbid a patient should start crying when we talk with them about it. So we work really hard on communication. In fact, I was just exchanging a series of text messages with some of my nurse practitioners, and they said, ooh, I didn't mean to send that to you. And I said, no, you needed to. We really need to be over communicating about this issue. So they were like, okay, thank you for not getting mad. They did a study back in 2008 with cancer patients, 343, and they said, have you and your doctor discussed what care you would have if you were dying? Now, what the patients didn't know was that they were all dying. They went through the medical records and they picked out people who had stage 4 cancer. Their life expectancy, on average, when they looked at it at the end of the study, from the beginning to the end, was 4.4 months. Only 1/3 of those patients had a conversation with their doctor about end-of-life care. And when they went back to the doctors and said, what the heck? They said, well, we didn't want to make them depressed. We didn't want to get them to lose hope. And there were studies baked into that survey that said patients did not lose hope. They did not become depressed. They hoped for different things. And your emotional state is really kind of something that's sort of baked into you. If you win the lottery, you're really happy for a few days until relatives you didn't know you had find you and start asking for money, and then you tend to revert to baseline. People who've suffered catastrophic accidents are depressed while they're in the hospital, and they tend to revert to once again to baseline. So when they talked with the doctor, said, we really need to do a much better job. If 2/3 of your patients who are dying don't know they're dying, that's a problem. And then coordination, the third C, is getting everybody on the same page. Now the families will frequently say, we can't give up. Dad, you got to keep fighting. And people get sick and tired of being sick and tired. There are worse things. When I talk with patients about end-of-life care and are we going to try to resuscitate, and the family go, well, yeah, what's worse than being dead? And so, well, come with me down to the ICU. I will show you what's worse than being dead. Being on a ventilator, being dialyzed, in pain, can't even scream, and you're stuck there, and the chances of you surviving are essentially zero. And I have that conversation probably every other day. So there are things worse than being dead. So let me go through Tim's myths for a moment. And the first one is that palliative care and hospice are giving up. And that's not number one on here, just so that those of you following along. It is not about giving up. It is about focusing on quality of life. Now, the thing you need to know is nobody gets out alive. Life is a terminal illness. I won't say the other part, but nobody gets out of here alive, so it is really and truly about quality of life. And at the beginning of life, you want a whole lot of curative care, but towards the end, patients actually do better if they get their symptoms managed and you don't do as much. I was going to circle back for a second when I was talking about prognosis. My mother was a librarian, by the way, when she died in hospice. So I'm going to keep throwing books out for those of you who like books. When Breath Becomes Air by Paul Kalanithi, he was a neurosurgical resident who developed stage 4 lung cancer. And one of his questions was about prognosis, and his doctors wouldn't give it to him. Now, he could have cheated. He was a doctor. He could have gotten in there and found out, but he was trying to be a good patient. But he told the doctor, if I've got a year, I'm going to quit my job and go home and be with my family. If I've got 10 years, I'm going to finish my training and I'm going to be a neurosurgeon for a while. And if I've only got 2 or 3 years, I'm going to work on writing a book. And his doctor would not answer that question. So he wrote most of the book, but his wife actually ended up finishing it because he passed away. Everybody needs to be thinking about end of life, and I'll talk about that in a moment. Myth 1, hospice means going to a facility. I can't tell you how many times I've gone out, because I make house calls, don't tell anybody, but I do that. So they'll kick me out of the AMA if they find out. Hospice means going to a facility. I've been with families in their homes and said, well, we really think that hospice is probably the way to go. And they said, no, I'm not going anywhere. And I said, well, how about if you stay in your chair and you're in hospice? Would that be good? And I said, yeah, I could do that. I said, okay, well, that's what hospice is. 95% of our patients are in their homes. Number 2, hospice patients cannot continue to see their primary care physicians. They can continue to see any physician they want. For the physician that's concerned with what the life-ending illness is, we end up paying them. So a lot of times the doctors says, man, no, you're good. But we are not an impediment to continuing to see your doctor. Hospice patients can only be in hospice care for a few days or weeks. This is a tragedy, not a fact. A third of our patients who come to hospice live 3 days or less. It's supposed to be a 6-month benefit. Our median length of stay right now, or our average length of stay, is 55 days, which is not quite 2 months. Our median length of stay, which is the middle number of patients, is 10 days or 12 days. So we get patients way too late, not way too early. In 10 years of doing this, I've had one patient that probably came a little early. And I actually had 2, but one of them dropped out with lung cancer and he was back in a week. He said, well, that was stupid. Number 3, hospice just for cancer patients. And I'll come back and talk specifically about the guidelines for patients with ALS, but it is for anybody with a life-ending illness with a prognosis of less than 6 months that continues to decline. Tim made reference to if you had a plateau, we are not allowed to treat chronic illnesses. That's nursing homes and home health care. So we're constantly having to document that the patients are declining. We're looking at weights, we're looking at function, we're looking at sleep. But it is not just cancer patients. Hospice can be very expensive. Actually, hospice is considerably less expensive than contemporary regular medical care, and I'll talk about that a little more in a few minutes. But Medicare pays 100% for hospice care, so it is actually considerably less expensive. Multiple states, as we've looked at the financial crises going on around, or Medicare and Medicaid, have tried to drop hospice. Louisiana was the most famous one. Bobby Jindal dropped the hospice benefit for Medicaid patients. He literally put it back in 1 month, because all those patients that were dying at home inexpensively at home in hospice suddenly started coming to the hospital, and the state's budget in a month went up that much. So they said, oh, bad idea, never mind. Tennessee tried to do it a few years ago, and they were presented that same data along with an article from Health Affairs and said, oh, never mind, we'll keep doing this. Hospice requires patients to stop taking medicines. This one really drives me crazy. We talk about pill burden. The average patient who comes to hospice is on 20 medications. The chances of a drug-drug interaction are essentially 100% when you get to between 8 and 9 medicines, so they're taking 20. So you're treating a complication with another pill that causes another complication. So we talk a lot about pill burden. And one of the things that we will frequently come back to is, do you need this in the face of a 6-month life expectancy? There is a wonderful website for those of you who like to look at these things. I see several pens going up, called The NNT.com. That stands for the number needed to treat. And what it is a website that looks at how effective medications are. And they have green is a good idea. You should take this medicine. Yellow, probably helps a little bit. Red, really not that helpful. And black, this is a bad idea. It actually has a worse, it does worser things for you. And it looks at treatments, it looks at testing, it looks at like treatment of moderate hypertension. You have to be on hypertensive medicine for 10 years for you to get some benefit. So we frequently will stop medications with the patient's permission. You know, we have patients who have cancer and they're on a cholesterol medicine. I'm like, you know, if you're on a cholesterol medicine, you've never had a stroke, never had a heart attack, and you have a 6-month prognosis, the chances of developing diabetes are 2% from the cholesterol medicine, and developing significant muscle pain or joint pain is 10%. So they actually have a red recommendation on thennt.com if you've not had a stroke or heart attack or other vascular disease. So, so we don't rip patients' medicines away from them. We do frequently say, gee, this is a bad idea. Patients with Alzheimer's disease who qualify for hospice are usually so demented that the dementia medicines do not work for them, or they are no longer working. Interesting little known fact is they usually only work for about 18 months. The side effects are horrific, and they are statistically significant. They are not clinically significant in the vast majority of patients taking them. And a lot of patients are taking both Namenda and Aricept or something like that, and the two do not work better than the one by itself. So in the top 10 lobbying groups in the United States, Big Pharma is in the top 10. So it is a significant problem that people are being sold stuff. And I remember seeing a drug salesman one time came in, and I'm going to circle back to this about one of the medicines for ALS. And I said, is this clinically significant, looking at the numbers that he had in front of me? And he said, no, doctor, but it is numerically significant. Well, I have a master's in epidemiology and public health, so I said, I'm afraid that really doesn't get you anywhere. So we do talk about pill burden. So we do try to get patients off of some medication, but it's in collaboration with the patient. We don't just like walk in and take the bag of medicines and walk back out. And the amazing thing is, a lot of patients feel better. You know, I can't tell you the number of patients I've taken away their cholesterol medicine because they were dying of cancer, and they said, I didn't realize I felt that bad until I stopped taking it. Only doctors can refer to hospice. We do like a doctor to refer to hospice, but it's not a requirement. We have patients as recently as last week that their doctor, they'd moved here from out of state. They didn't have a doctor. The daughter was like, oh my God, went to get my mom because I knew she was failing, but I didn't realize it was this bad. And we sent somebody out and we got them admitted. Hospice means giving up. I've already addressed this a little bit. No, it doesn't. My least favorite, morphine is prescribed and causes premature death. No, it doesn't. I've used morphine for a lot of things besides pain, and it works really well. A patient must be a DNR. That means do not resuscitate or allow natural death. That is, we are legally kept from doing that. It does seem a bit of an oxymoron to be in hospice and then still want to be fully coded, but we do have patients that do that. It's always kind of a little strange, but you know, the nurse will call and say, I think the patient's dying. And I said, well, it says on their post form that they want to be fully coded, so do CPR and call 911. And lastly, hospice causes patients to die sooner. Well, I'm going to come back and touch on that one again, and that's the question of how do I sleep at night? And I get doctors ask me this. Remember, I said we just started teaching about this, so doctors are really just kind of learning this. I have that copy of Datul Gawande's book because I have a box of them in my office, and when I have medical students rotate with me, I give them one. That's my present to them. Here, you need to know more about this than I can teach you in 2 weeks. So how do I sleep at night? First of all, in general, patients in hospice live longer, and the average is about 3 months longer than they do not in hospice. That goes across heart failure, cancer, neurologic diseases. I can't speak specifically to ALS because there's not the data out there, but on average, most patients live considerably longer. Their care is less expensive. I've already talked about that. And they have much greater satisfaction. They have better quality of life. But the problem is if nobody tells you you have a life-ending illness, then you keep going back to what you know, which is go to the emergency room, go to the hospital. There are good studies. Actually, there was one in the Wall Street Journal was one of the first ones talking about having a palliative care service at Virginia Commonwealth University, and they were tracking hospital expenditures and financially, and then palliative care consult palliative care at 7, 10, and 15 days, and their expenditures went down because once people know they have a life-threatening or life-ending illness, the most common thing I get is, well, what the heck am I doing here in the ICU? Can I go home? And I routinely send patients out of the ICU to go home and be with their families. I said, you can, it sometimes comes down to you can die here, you can die there. And that's a real shock to hospital staff they could die. I said, well, hospice doctor standing at bedside is a bad prognostic sign. The question is not if they're going to die, because everybody is, it's where they're going to die. And if they want to be home and be with their family, that's what I'm here to help facilitate. I want to say a few words about advanced care planning, now that I've told you how I sleep well at night. Were you able to find the? Was not, okay. Well, I brought the website, so those of you with pens. It is always too early until it's too late. And this is about advanced care planning. Tennessee is actually a leader in the country about advanced care planning, and that is saying how you want the latter part of your life to go. Once again, it's not about dying, it's about how you want to live the latter parts. So for those of you that want to take notes, you can go to www.advanceddirectivestn, all one word, .org, and they have the forms there. You go under how, and it'll show you the form along with an explanation. Or you can go to Honoring Choices TN, and they have a little video of me talking about advanced care planning. How many people here have an advanced care plan? Hold your hands up. 1, 2, 3, 4, 5. Okay, so less than half. I periodically do this with my hospice staff, and they're less than half. I'm like, guys, I keep saying, nobody gets out alive. I have one, and I realize that this is an awkward, difficult conversation to have. A story I like to tell, we have a lake house on Douglas Lake up in Dandridge, and I was there one fall, and I was getting out the little things to cover the faucets and close the house up, and my daughter happened to be there and said, hey, let me show you how to put these on. And she said, why? And I said, well, so you'll know how to put them on in case I'm not here. She said, why wouldn't you be here? Are you sick? Is there something wrong? And I said, no, I just want you to know how to put this on. And she came back again. She said, is something happening? And I was like, no. And I said, but I am a hospice doctor, so I'm realistic about, you never know when you're going to go. And so she said, so what does this mean? I said, it means I don't want the faucets to freeze. Would you please watch while I do this? So I have one. As I mentioned with my wife with a heart attack, she did not have one. So once she got out of ICU, I said, let's talk about end-of-life care for a few minutes. She said, well, you're a cheery soul. And I said, and my wife's a nurse. I mean, she does this as well as I do. So everybody ought to have one, particularly if you have an identified life-threatening or life-ending illness. But when I talk to medical students, I show a slide that has Nancy Cruzan, Karen Ann Quinlan, Terry Schiavo, and I should add Brittany Maynard. These are all young women that made case law around dying. You never know when it's going to come. And it's not the piece of paper, it's the conversation with your family. Now, there are several wonderful opportunities to have this conversation. The first is April 16th. That is National Advanced Healthcare Decision Day. You might catch the implication, death and taxes. There is also at Thanksgiving, we in our community call that Talk Turkey Day. You've got your family there, there's good food, maybe adult beverages. What a wonderful time to say, hey, if I died, this is what I would want. So it's another chance to have that conversation because we so often go through life never having this conversation. And like I said, I was kind of caught flat-footed with my wife. She knew exactly what I wanted, but I'd really not asked her what she would want. And so I think I'll go on to talk a little bit about ALS and specific and kind of where we are with this. We are probably more helpful from the palliative care side than we are from the hospice side. And I was going to tell you the neurologic point where to be in hospice patients needed to be is decline in motor or sensory function, communication, mobility. We have what we call a palliative performance score, which is a how well do you function, and it looks at walking, self-care, hobbies, eating, and level of consciousness. Hopefully most of us in this room are 70+%, which is when you just start having trouble with walking. By the time you're down to 40%, you're spending most of the time in the bed or chair, and that's when we are usually talking about hospice appropriateness for ALS. Respiratory function impaired, nutritional impairment, dysphagia, which is trouble swallowing, aspiration pneumonia, recurrent UTIs, sepsis, or decubitus. So actually patients have to be fairly far along before we're talking hospice, or they have to be progressing pretty rapidly. Remember that two-thirds of the patients that are diagnosed with ALS, they start with basically clumsy. They're dropping things, they're tripping on things. I can't tell you how many times I've had that conversation. Well, we just thought Mom was getting clumsy, and she started tripping and falling, and then she broke her hip, and then she couldn't raise her arm, and then the diagnosis was finally made. But another third of patients are diagnosed for what they call bulbar symptoms. That's symptoms in the neck and throat, trouble swallowing, drooling, choking on things, having trouble speaking. I was preparing to give this talk, and my youngest son mumbles. I mean, he's famous in the family for it. And I said, now he's been mumbling for 10 years. It's not that. But I had that brief thought in my head as I was writing this, going, well, maybe that's what's wrong with him. So the really frustrating thing, going back to that communication about prognosis, is it's really variable. The shortest I ever saw, I went and saw a lady for palliative care, and she was having trouble swallowing, and she'd been hiding it from her family. She lived alone, and she'd basically done everything, I mean everything, to keep her family from finding out, including saying that she'd sprained her ankle, which is why she wasn't getting up from the chair, etc. And she died in 2 weeks. That was the fastest I've ever seen. Usually we're talking months. The average is 30 months from onset of symptoms. But then we have Stephen Hawking, who was diagnosed as a young man and just passed away a few weeks ago at the age of 76. So, once again, that kind of gets back to what do we know? The most common thing, and the interesting thing when I went back and looked, is how little data there is to support a lot of stuff specifically around ALS. Most common problem that patients have other than mobility is ventilatory failure, and that's the reason that most patients pass away with ALS. The institution of BiPAP and CPAP has extended lives, but it's led to an interesting conversation. We have a number of patients. After a period of time, the trilogies that some of you may have heard of, which are basically mini ventilators, came along, and for a long time we didn't have patients with ALS on trilogies. We started doing it about 2 years ago. I actually had a not quite a shouting match, but it was less than pleasant conversation with an insurance company. He said, "You're just making this person live longer. That's not what hospice is for." And I said, "I'm about comfort," and this patient was smothering, and so we made sure that they had a ventilator. But patients do live longer and more comfortably if they're getting BiPAP or some other sort of ventilatory support. Then, with the new onset of it used to be the mask, and I've had a number of patients who said, I want to stop. I don't want to do the mask anymore. And we've stopped and made sure they were comfortable as they passed away. But with the nasal pillows, it's gotten a lot easier to eat, to talk, to breathe with those. So that's seen kind of a jump in the use of the trilogies and BiPAPs. PEG tubes. That is percutaneous tubes in the stomach. That's probably what ALS is one of the legitimate reasons, if you will, for getting one. They have become so pervasive, and I mentioned my wife's a nurse. My wife is specifically a nurse in a GI lab where they put in PEG tubes. And literally on an almost weekly, monthly basis, she says, "Gee, I wish you could have talked to this family before they did this." Because the reason that they most commonly get them is for dementia patients who've forgotten what food is, forgotten how to eat. You put it in their mouth and they've forgotten what to do, and the family says, "Well, I don't want Mom starving to death," and I will literally kind of scoop up some food and hold it out to them, and they behave like a vampire, offered a crust. They're like, "Ah!" I said, "They're not starving. They're choosing not to eat because they've forgotten what eating is." But lots of demented Alzheimer's patients will get a PEG tube in, and there is, in the palliative care literature, there is actually an article called the PEG tube death spiral. And that is that because they're so demented, they put the tube in, they pull it out because it's something funny stuck in their stomach, and they don't feel pain like we do, so pull it out and we put it back in. And then we chemically or physically restrain them. And then they laid flat, and the stuff that was pumped into their stomach goes up and gets into their lungs. And then they get aspiration pneumonia and they die. However, in ALS patients, there is some evidence to show improved nutrition and some small evidence to show improved survival. Once again, studies are not big enough to really have a lot of statistical power, but if you're going to go down that route, you want to do it fairly early on. There are actually specific parameters related to lung function that you should have it done before then. But if you've got a reason that you can't get food from here to here, that's a reason to have a PEG tube, but it is not a cure-all. People still aspirate, they still pull them out, they still get clogged, but it is something else that we offer. Another common problem for patients with ALS is head droop, and a lot of times cushions, first soft cushions and later hard cushions to keep the head up, because one of the primary problems that people have is muscle strength in the neck. So you've seen the pictures of Stephen Hawking, he was kind of like that. Another embarrassing problem for a lot of people is the medical name is sialorrhea, which is drooling. Once again, you can't control your secretions because you can't swallow, you can't spit, so it just kind of tends to drool out the side. There are medications that will sometimes help with that. There are other interventions, including botulism toxin to inject in the salivary glands. It lasts about 3 months and cuts down on how much drool the patient makes. And even if you really want to go all out, there's radiation to the salivary glands. I do 1 to 5 shots, and I am not a radiation oncologist, but that was something else that I found that seems to help. And literally, I was really surprised because radiation usually takes weeks to work, but in this case, it works within a couple days for patients who are having a lot of trouble drooling. Another common problem is pseudobulbar affect, which is uncontrolled emotions. My father-in-law had a stroke and it affected that area. And he would suddenly, you'd be talking to him, he'd just burst into tears. And the first couple times he did that, I was kind of like, did I say something? No, it's nothing to do with anything we're talking about, it just happens. And of course he was horribly embarrassed by it, or inappropriate laughter, inappropriate anger. And there is a new medication for that called Nudexa, which is an old medication or combination that is a combination of cough medicine, dextromethorphan, and quinidine, which is a heart medication. Now, I talked about Big Pharma a while ago, and I'm going to circle back to that. There's actually an article in the New York Times about now that they've got one indication, which is for pseudobulbar affect, they are selling the heck out of it to nursing homes and other facilities for patients with dementia to try to keep their anger under control. And there is a big investigation going on right now because the company has gone way past what they were supposed to be marketing it for. And quite candidly, you can get the same effect with some dextromethorphan and quinidine done separately. But of course, as we've seen with the explosive rise in drug costs, this is a very expensive medication made from combining 2 very old, cheap medications. So. And antidepressants will sometimes help with the pseudobulbar affect also, but quite candidly, doctors prescribe what people are out there selling. So it is sometimes some hospitals actually do what they call counter detailing, which is going out and saying, the old cheap stuff still works. It's just that it's off patent, so anybody can make it, so they're out selling the really expensive stuff. And in hospice, we see that all the time, patients on really, really expensive stuff, that there's an alternative that are literally pennies that they could be getting. Other things, depression, common thing to get depressed about. One of the things that astonished me was that I figured anybody in hospice would be depressed, and you'd be surprised how many people are not depressed. But depression is something you certainly want to look for. I was giving a talk about depression in hospice, and I came across a screening questionnaire that was 100% sensitive, which means everybody who has the illness will be positive, but of course some other people will also be positive. Was, have you felt down, sad, or depressed in the last 14 days, and if so, how many? And if it was more than just a few, then they were probably had depression. You would do some additional screening. So I took that question, I went out to see a patient, and I said, have you felt down, sad, or depressed in the last 14 days, and if so, how many? And she said, 11 out of 14 days. I was hoping you'd ask. And I was like, well, that's pretty specific. I think we need to give you something for depression. One of the things we use Prozac, Paxil, citalopram, Lexapro. One of the things we tend to use, because it works really quick, is Ritalin. And Ritalin works really well, the stuff you give kids with ADD, and it usually, where the other antidepressants will take 3 to 6 weeks, Ritalin works in about 3 days. Obviously, you have to be careful with people who've had like cardiac issues and stuff, but even with them, you know, it helps. If you've got a life expectancy of 6 weeks or less, you don't want to wait 6 weeks and on the last day go, hey, I'm feeling better. Pain, we are terrible, and we are getting much, much worse. Effective July 1st, I'm going to put an exact date on it about treating pain. The state of Tennessee has in its wisdom passed a law that says we have to be very limited in how much pain medicine we prescribe, particularly pain clinics and stuff like that. A number of us in the hospice and palliative care community went to the state legislature and said, oh my God, you're about to put us out of business. So they created exceptions for hospice and palliative care patients. But what we're seeing, and I've had this conversation at several of the hospitals here, is that the doctors just go, I don't treat pain, period. And we're going to see a lot more patients. I'm already seeing patients being referred not because they have a life-threatening or life-ending illness, they are being referred because they have chronic pain. And that's going to be a bigger and bigger issue. As you probably know, in politics, you paddle on one side of the canoe for a while and you paddle on the other side. Right now we're paddling on the right side, which is keeping people from getting pain medication. Now, I just finished the book Dreamland, which is about the opioid crisis. If you have an interest in that, it is really scary. And once again, going back to Big Pharma, it comes back again and again to Purdue Pharma pushing OxyContin as a addiction-proof medication. Tee-hee, guess that was wrong. They got sued they paid a $634 million fine, of which they made the CEO pay $1 million personally for that little lie. And Dreamland, the book, talks about that some. In fact, the first doctor that said, God, I'm seeing a lot of patients, he was in a substance abuse center, I'm seeing a lot of patients who are coming in with this new medication, OxyContin, and they seem to be addicted to it. And he wrote a little squib for the local Portsmouth, Ohio paper. The next day, the lawyers from Purdue Pharma called him and said, if you ever speak about or write about OxyContin being addictive, we will sue you into oblivion. So just kind of look where the money comes from. But pain is a problem. And when I mentioned talking about sleep, we help patients feel better. We address their pain. We address their symptoms. Shortness of breath. Opioids, morphine helps. I treat patients who are short of breath who do not have pain because morphine and other pain medicines will help with that sensation of breathlessness. I had an interesting chat with a cardiologist a couple years ago, and I said, so your patients with heart failure, when do you start, and they get really breathless? He goes, yeah, that's a problem. I said, when do you start giving them morphine for their breathlessness? You'd have thought I asked him, when do you crucify them? I mean, he was just shocked. I said, tiny doses of morphine really help. And if you're not stressing about how dyspneic and short of breath you are, you're going to live longer. That's part of why patients in hospice do live longer, is we're addressing their symptoms. And he was just shocked. And I said, have you ever done it? He said, no. And I said, well, you ought to think about it, or send them to me and let me do it. And he was good with that. I wanted to just mention Riluzole for a second. That's another really expensive medication, but it shows a 2 to 3 month survival benefit. We will not pay for that for patients who are in hospice because it's really, really expensive. But the side effects are fairly terrible, and fatigue being the worst one, and it adds maybe a 2 to 3 months in terms of survival benefit. So a lot of times, quite candidly, in patients with ALS, we'll say, well, take it for as long as you think it's doing you some good, and then we'll probably stop it when you come to hospice and focus on just trying to keep you comfortable. So I've talked a little bit about kind of end-of-life care, and you guys have been really good, and I was hoping you'd interrupt me a few times, but I'm going to stop and ask questions. I know there's always a few seconds where everybody kind of thinks about what questions do they have, but I'm going to stay in here and wait till somebody asks me something. So, yes, sir.
I'm not sure if it's Riluzole. Is that the one that they made in Japan for ALS?
Radicava.
No, that's right.
Radicava.
I'm listening to them, so I'm not sure.
And it's supposedly, now it's real expensive, but it's supposedly supposed to have add 30% life expectancy, onto it. Do you know anything about that?
Regrettably, I do not. I'm not a neurologist.
I'm currently doing Radicava right now. I've got my port put in and everything. My understanding is it really does not extend your life, but it lessens the symptoms as you're going through. So personally, I couldn't tell any difference first 2 or 3 months, and there was a little snafu with the insurance company. So I was off of it for a month, and I could tell my hands degenerated rapidly. So I'm back on it. It is very expensive. They billed us $48,000 for the first 2 weeks. So there are some things out there. There's a company called Searchlight, and they will help pay your deductible for that. So if you're thinking about doing Radicava, go online, get involved with Searchlight, or I can pass them up to Laura here. Maybe we can do some things there too.
Okay. I know there are a couple of new ones coming out. I know they're all eye-poppingly expensive.
Well, I was in Washington D.C. here a few weeks ago, and we got the right to try bill passed.
Yeah, I saw that.
But the thing is, the insurance companies aren't going to pay.
You can try it, but you can't afford it.
Yeah, exactly. So it was a kind of a double-edged sword, but at least the opportunity's out there now.
Mhm.
So some of these that are passing the second phase, the clinical trials, now we have access to them. And some of the drugs in Europe that are showing some success, we're going to be able to get access to those too.
Yeah.
So that's kind of exciting.
Well, the one that surprised me with the right to try thing was that they did not connect it with medical marijuana or anything like that. It was kind of like, there's something that's been around for a long time. I have patients periodically will tell me, well, I'll say, as I'm doing my history and physical, they say, well, have you ever used any illicit drugs? And they'll say, no. And I'll say, really? Not even marijuana for, appetite or pain? And they go, will you kick me out of hospice if I answer the question? I say, no, I don't care. I said, we're not a medical marijuana state, so I can't give it to you, but the short answer is I don't care, and I think in some people it might help. So, but
I'm doing a clinical trial at Vanderbilt right now,
Uh-huh.
Fortitude, and that was one of the questions too, was, are you taking medical marijuana? I do a CBD oil
yeah.
that has no THC in it, but
Well, the CBD oils are only indicated for intractable seizures, as I understand medically, but I've got a number of patients that are using them. And there was a really sad case in Georgia where a family had a child who was 15 and was having uncontrolled seizures, and they gave him marijuana and his seizure stopped for 2 months, and they just mentioned in passing to his counselor that they were doing it, and the counselor turned him in and they took the child away. So, and he went back to having seizures because he was no longer having his.
and that was actually how I got introduced to it. Dr. Vanderbilt, her son,
Mhm.
was having seizures too, so she basically got her own line, pharmaceutical grade.
Yeah.
CBD oil, so.
Well, you can find it online, so. Yes, ma'am. Pardon? Yeah. Yeah, I had somebody one time ask me, where do you get it? And I said, I don't know, I'd have to ask my kids.
She gets hers at the Hemp House here in Chattanooga.
CDO.
Yeah. Well, you can get them, and I see the ads all the time, so. Yes, ma'am.
Can you use hospice and home health care at the same time, or by the time you have hospice, you're not using that any longer?
Right. You can do palliative care in home health, and I do that a lot.
Okay.
But hospice does all the things that home health does plus the others. But in home health, you can still get infusions and stuff that hospice would not do. So I do a fair amount of palliative care with home health agencies.
Okay. And with the palliative care, when that decision is made once somebody is pretty much relegated to the chair or a bed, right?
No, that was hospice.
Hospice,
Yeah.
okay.
Palliative care can be earlier on.
Okay.
I would say when the patient's beginning to have significant symptoms or debility from their illness, but not all the way down to where they're looking at hospice.
Okay, I have a question.
Yes, ma'am.
I'm on a Facebook group, ALS.
Mhm.
They were really telling us that hospice was a bad thing. I mean, in the situations they.
Who are they? I'll talk to them.
Well, she said like her husband's power chair, that the battery went out.
Mhm.
And that they needed a new one. Medicare said Medicare won't pay for it, because they said, okay, if you're in hospice, we're not gonna pay for a battery for your power chair.
Okay.
You're fixing to die. Kind of like, that attitude.
That's like that conversation I had with the insurance company. They said, we don't want them to breathe, just give them morphine.
I mean, does it limit the things that she may need?
There are limits. Hospice will not pay for a powered chair. It kind of depends on the individual hospice specifically about something like a battery or a repair. Some will, some won't.
I mean, like she has a cough assist and different mechanical stuff at home. Is that would hospice
sometimes they won't.
limit? that
Usually,
kind of stuff?
yeah, there are limits on what they will do for those kinds of things. Tim, do you want to say any more about it? We try very hard to accommodate our patients, but
And it never hurts to ask.
Yeah.
We've had ALS patients come on service and they're waiting to get the electric wheelchair. And we ask them to get the wheelchair and then we start providing care because we absolutely don't want to interrupt you getting your wheelchair. But I think with the batteries and things like that, I think that's absolutely optional, that we could do something like that.
Yeah, it's a struggle, and to be very candid, part of it is how hospice gets paid is basically by the day. I have doctors who've told me, oh, I know you give people, you get paid to give people morphine and kill them, and I'm like, and to one doctor, I said specifically, I said, no, we get paid by the day they're alive. There is no bonus for finishing the patients off. It makes financial sense, aside from the fact it's good human nature to keep the patients alive. But we get paid per day, and out of that comes medication, equipment, nurses' aides, me, Tim, and so we do have to be careful about how we spend our money. But at the same time, we're a not-for-profit. We're the only not-for-profit hospice in the area. We try very hard to make sure that we service our patients in an equitable fashion. Yeah.
What you saying about the battery for her wheelchair?
Uh-huh.
Did you get your wheelchair through the insurance company? Go through your insurance company of where you got your wheelchair from, because I just had tires and stuff put on this one here, and the insurance pays for it.
Were you in hospice at the time?
No.
Okay, well that's what they're saying is
She's in hospice.
well,
No,
if she was in hospice, they might not do that.
I heard some people told me that once you get into hospice, that they're not gonna pay for anything like if she needs a battery for her chair or anything, extra like that.
Yeah, because hospice
Batteries
becomes
may not cost much.
responsible.
I don't know how much they are.
I don't know.
I figured.
If they have medical attached to them, they're triple whatever they would be otherwise.
John,
Yes, sir.
I've always known hospice to be in the hospital, like you said, to drip and that's all.
Mm-hmm.
Now, we're talking that you can have someone come to our home
Mm-hmm.
and help take care of him and give him whatever he may need and things like that.
Yeah.
Like you said, so he's gonna be at home when he finally passes away.
Yeah.
Okay.
Well, hopefully a long time from now, but
Well,
yeah.
yes, we are, but I'm not talking right now either, but I just wanted to make sure, because like I said, all I ever known was you go to the hospital and that's it.
Yeah.
Yeah.
Well, and that's, the studies show if people have had an end-of-life conversation and they've talked about hospice, and this was a survey done on elderly patients, less than 10% went back to the hospital to die. If they didn't have a talk about, gee, this is fatal, this is going, they bounce back to the hospital repeatedly, more than half the patients die in the hospital, and about 40% of them die in the ICU, which is where nobody wants to pass away. So the goal is to be home. Now, I want to clarify that hospice workers come out and help, but they do not stay there 24/7. I mean, I had one family, they called and they said, oh, your nurse just left. I say, yeah. And they said, we thought she was going to stay till the end. And I said, well, it could be 6 months. So I think her family would object to that. Yes, sir.
Is there a substitution for Nudexa?
Well, it's 20 milligrams of dextromethorphan and 10 milligrams of quinidine. You could buy the two separately and take them.
Over the counter?
Pardon?
Over the counter?
Yeah. Well, the quinidine, I think, you can actually use quinine, which is what's in gin and tonics.
You just made somebody very happy.
Yeah. I don't know what the milligrams are in there, but the quinidine is a prescription medication. But dextromethorphan is, you can buy that usually by the checkout counter. But I would at least try an antidepressant before I went down that route. I'm not saying it doesn't work. I'm saying it's a really expensive variation on two old drugs that is being oversold in terms of what it does.
And
Yes, ma'am.
You're familiar with Riluzole, the Riluzole, or how?
In passing.
Okay, and you mentioned that the side effects being fatigue
Mhm.
and.
That's the one that most people quit it over, is they just feel exhausted. Now, I am not a neurologist. I have never written a prescription for Riluzole, but quite candidly, most times when people come, they are stopping Riluzole when they're coming into hospice.
I actually took it for a while, and just the overall feeling it gave me was horrible.
Mhm.
I mean, fatigue maybe too, but I just didn't feel good.
Did you have a fuzziness and all?
Yeah, and I don't want to say depression, but I just didn't feel good. So I stopped taking it. So.
Anything else? Yes, ma'am.
If my mom's just moved to town, she has ALS, and so we're looking for a primary care physician.
Mhm.
Is there a possibility if we get her enrolled in palliative care, that would?
We try to just do the palliative care part,
Okay, so still.
but we would see your mom. Yeah, but with the whole pain and opioid thing, I've had a couple of doctors who once I picked up the patient for palliative care, they dropped the patient as the primary care doctor, which kind of made me mad. But I would still encourage her to have a primary care doctor. Palliative care, hospice is 24/7, 365. If you get sick at 2 in the morning on Christmas Eve, a nurse will come out and look at you. Palliative care is more by appointment during the week. We don't do call. I tell people if you have an emergency at 2 in the morning, call 911. That's why that we do that. And it's you call and say, "Gee, mom's not looking as well. Can you come out in the next few days and look at her?" But quite candidly, I have one other doctor and a couple of nurse practitioners, but I personally cover 6,000 square miles. So when people say, "Come quick," that depends on where I am at the time. Other questions? Well, I thank you very much for your time and attention. It's been my honor to come and talk with you and help see you along on this journey for those of you who are on it. But anything I can do to help, feel free. The brochure has the phone number for palliative care on the back of it. I thank you for the opportunity to come and talk.
Thank you.